Welcome to this podcast reviewing the functional anatomy, kinesiology, and biomechanics of the lumbar spine. This is for Musculoskeletal 2, DPT 6020, spring 2019. Hopefully before beginning this podcast, you've had a chance to look at Dutton, pages 1425 to 1442. If you have any questions, please review those pages. The objectives are listed here, kind of looking at major structures of the spine and appreciating their role in contributing not only to function but also mobility and physiology of the thoracolumbar spine. Before we get into too many of the individual areas and functions, let's start by appreciating the vertebral column and the different regions. Specifically note that in the lumbar spine, the main role is to support the trunk for upright posture as well as to protect the spinal cord, with movements being flexion and extension followed by lateral flexion and rotation. But note specifically that these do not occur in the same proportion through all segments. If you look to the right side of the screen, lateral flexion and rotation are each limited to less than 5 degrees at every level, with the exception of L3 to 4 with lateral flexion. That's actually 5 to 6 degrees. However, all of these motions are 0 to 5 degrees of total mobility. So when we get into passive physiologic intervertebral motion testing, we need to appreciate that the movement is negligible and is likely non-palpable. And so we'll be talking about does it move, does it not move, being really the only criteria. Your ability to discriminate, is it hypomobile, hypermobile, or normal is less likely to be applicable in this case. However, the lumbar spine is specialized specifically for flexion, not so much for extension due to the bony architecture, which we'll see in a moment, but flexion is actually quite good, anywhere from 5 degrees and above all the way up to about 12 degrees at L4 or 5. If we look at the typical vertebra, on the right side of your screen, you can see both the cervical and thoracic vertebra. Note now that as we get to the lumbar spine, the angulation is at a 90-degree angle for the superior and inferior facets. The body is more cylindrical and is responsible for the growth and height of the vertebra due to that hyaline cartilage that covers the body. The neural or vertebral arch is also there, and you find then the pedicles and lamina supported along with the superior and inferior processes. Ligaments are pretty important in the lumbar spine, but there's an interesting note here. They are not equal. So the anterior longitudinal ligament, or ALL, is fairly broad and extends all the way from the occiput to the sacrum and really helps to blend with the disc, and then has a major support function not only of the vertebral column but also in terms of reinforcing the disc on the anterior surface. However, in a moment you'll see a visual where the posterior longitudinal ligament, while it is the counterpart of the anterior longitudinal ligament and also runs from the cervical region down to the lumbar region, so the length of the spine, it is far narrower in the lumbar. And this is one of the reasons why so many pathologies are purported to exist in the lumbar spine, because they lack that extra degree of static reinforcement. And so both the ALL and PLL function to limit extension and flexion in their own right, as well as to reinforce the disc. But again, PLL has a lesser role. So as we visualize this, hopefully you can appreciate that the anterior longitudinal ligament is almost 2 times the width of the posterior longitudinal ligament. For intervertebral discs, it's most important to note that they serve as the connection point between the vertebral bodies, and they're numbered by the vertebra they connect. Unfortunately, my blue arrow is off here. It's pointing at the L1-2 disc. It should be down a level if it were to be accurate, where it would be pointing at the L2-L3 disc. However, the function and role of the discs is not impacted by that. So again, the discs function to bind the vertebra together. They function to absorb shock as well as to allow motion between the vertebral bodies, also then creating a passage for the nerve roots through the intervertebral foramen. Finally, because of their nature of being thicker anterior and thinner posterior in the cervical and the lumbar spine, they actually help to form the curvature or the lordotic curvature that we see. It's just the opposite as you get into the thoracic spine, where that curvature is actually a kyphosis. For the intervertebral disc, not only does the shape then correspond to the shape of the body, but the size is also dependent upon the region. So for example, in the cervical spine, we see a 2 to 5 disc to body ratio. However, when we move to the thoracic spine, it becomes 1 to 5, and in lumbar, it's 1 to 3, such that the discs make up 20 to 25% the length of the vertebral column and are highly important for then maintaining the height. When we look at the discs from a vascular level, we find that they're primarily avascular. Only the periphery of the disc receives blood supply, and that blood supply is necessary if it is to heal due to injury. And so injury not on the periphery is not going to heal very well. And so we need to be mindful of how likely a disc pathology is to heal, as well as the time frame. There is also very little nerve supply. Only the outer third of the annular wall is innervated. There are pain-sensitive structures though that surround the discs, such as the ligaments, the vertebral body itself, as well as the nerve roots. And the nerve roots then are likely the most common anatomical structure to be relaying information such as pain. Spinal nerves then, we have 31 pairs of nerves within the cervical spine. There are 8. Within the thoracic spine, there are 12. As we move into the lumbar spine, we see 5. Sacral has 5, and then there is 1 coccygeal nerve. And they're named according to the relationship with the vertebra. The one exception would be C8, which actually lies between C7 and T1. And so when we think of this, a disc bulge is going to affect the nerve root below the level of the bulge. So in this case, we're looking at the L4-5 disc. The lumbar disc protrusion does not usually affect the nerve exiting above the disc. So in this case, the L4 nerve. The lateral protrusion at disc level L4 and 5 is going to affect the L5 spinal nerve. And so hopefully you can appreciate that variance. The joints of the vertebral column are really 3 joint complexes, or what we might refer to as motion segments. You have 2 paired facet joints, as well as the joint then between the disc and the body. So the facet joints are the superior facet of the vertebra below and the inferior facet of the vertebra above. And they're considered plain synovial joints with support by a joint capsule, thus why oftentimes facet dysfunctions are so impactful, because there's a joint capsule, but there's also an innervation, and so facet pathology can be quite debilitating for our patients. Movement is often gliding. The direction does depend on the facet orientation, so keep in mind in the lumbar spine, those are oriented at a 90-degree angle, and that will vary throughout the spine, whether you're in the cervical, thoracic, or lumbar region. A helpful graphic to kind of consider all the different pieces to the spine, and I think we've seen this before in Musculoskeletal 1, but you have the ALL in the front part of the disc, you also have the PLL, and then the spinal cord and nerve root levels, the vertebra or the backbone, and then oftentimes we talk about a Scotty dog. And so the dog will sleep on the disc, the spinal nerve exits under the armpit of the dog. The facet joints are where the dog on top steps on the ear of the dog on the bottom. And then the dogs have a big piece of duct tape on their butts that kind of hold them together. And that's a helpful way to kind of think through this. So let's be more specific now to the lumbar spine. First, the lumbar vertebra, we've already discussed, are rather cylindrical. And their main function is to support body weight, and that size is going to increase as the column descends, really most markedly from T4 inferiorly. The external layer is compact bone, while the internal layer is more or less trabecula, and is very, very active in terms of hematopoietic tissues, thus blood forming. The articular processes, again, you have both a superior and an inferior articular process, and those will be oriented at a 90-degree angle. From there, you see also the pedicles and lamina posterior to the vertebral body. They're short and cylindrical. The pedicles really are the only connection between the posterior joints of the segment and the vertebral bodies, and through that pedicle is often where we will see fractures, and we'll talk more about that as we get into the differential diagnosis section of this unit. When we look at the intervertebral discs, they are a source of much focus as well as debate. The annulus fibrosus is dense fibrous tissue and consists of fibrocartilage. Really, there are these 10 to upwards of 25 sheets of concentric type 1 collagen tissues that are bound together by the collagen gel. Each layer of fibers are oriented. It's been proposed at about a 45-degree angle, but really it's about a 65-degree angle from vertical. And each layer is in the opposite direction from its adjoining layer, which allows about 50% of the fibers to be under rotational force stress at any time. Okay, and they're also going to be attached to the periphery of the vertebral body via the vertebral end plates. The nucleus pulposus is very well developed not only in the cervical spine but also the lumbar spine, and is about 80% of water content at birth, down to approximately 68% in the elderly. And that loss really is in childhood, while about 6% occurs in adulthood. There's a containing component of chondrocytes and proteoglycans and collagen fibers and proteins and elastins and all this other aspect that exists there. But as we go, we see that decrease in height due to desiccation of the disc. Finally, the intervertebral disc, again, functions to distribute any compressive stress or axial load, as well as providing flexibility at lower loads and stability at high loads. So we need to be mindful with that. Our lumbar vertebra do have the intervertebral foramen or nerve root canal laterally, and here we will find the exiting nerve root. It's going to be bordered by the superior and inferior vertebral notch. It's also referred to as the vertebral arch or neural arch, and it's the two pedicles and lamina that form that vertebral arch. The arch and the posterior walls of the vertebral body form the vertebral foramen. The vertebral foramen then would be the central canal, or the location that we would find the spinal cord. With this, we see the pedicle connecting into the inferior and superior articular processes, as well as the transverse processes that then connect via the lamina into the spinous process. And so really there are 7 processes that arise from the vertebral arch. We find 2 articulations that exist between consecutive lumbar vertebrae, most notably the lumbar vertebral bodies and intervertebral disc, and then again the bilateral facet joints. The main function of the facet joint, or what we may refer to as the zygoapophyseal joint, is to protect from anterior shear, rotation, and flexion. And so here it produces spinal motions that include coupling movements, and we'll talk more about that as we move into biomechanics. Minimally restricts, though, extension and side bending because of the way that they're oriented. They're more of a J or C curvature, and you can kind of appreciate that if you look to the right on that superior facet on the left. There's a slight curvature there, and so it's not so much that the facet joint limits extension and side bending as it is other kind of osteology pieces. The ligaments we've already talked about, that being the anterior longitudinal and posterior longitudinal, but there are a few others that are important, such as the ligamentum flavum, which sits just anterior to the spinous process. The interspinous ligament that's going to bind each individual spinous process one unto the next. Supraspinous ligament, which is the most superficial to the spinous process. And then finally the iliolumbar ligament that we see as well. For the lumbar spine, there's a variety of muscles that are going to be important as we start our discussion on differential diagnosis and discussing core stability and things along those lines. We'll bring these muscles up in greater detail. However, the quadratus lumborum, or otherwise known as QL, and then the erector spinae and multifidus are really the ones that get a lot of the attention, followed by the abdominal muscles such as the internal and external obliques, transverse abdominis, and then even into the pelvic floor. The erector spinae is made up of 4 muscles and is paired one side into the next. You also have accessory muscles known as rotatories and intertransversi, which really function to contribute to more of a proprioceptive motor control and position sense, or what we may say kinesthetic awareness piece. Specifically, the quadratus lumborum sits on the back, and it's going to run diagonally from the rib and spine inferiorly and laterally towards the iliac crest. It is a deep layer of the dorsolateral abdominal wall, and when acting alone, will flex the trunk, and then will extend the trunk when acting bilaterally. Additionally, it's attaching not only to the lumbar transverse processes, but also to the 12th rib, and then serves to laterally flex the vertebral column and stabilize that 12th rib during deep inspiration or breathing. You see the neural innervation there. As a group, again, there are 4 muscles that make up the erector spinae. They are important in terms of lumbar stabilization, as well as providing compressive forces along the spine, which serve to not only dynamically stabilize, but also allow for a variety of movements. So they are going to be assisting with trunk extension. They're going to resist anterior shear. They will also help with spinal stability and enhance the speed of the leg. Additionally, we talked about how the disc has a role in the spinal curvatures, but here also the erector spinae help to stabilize those spinal curvatures. And the medial branch of the posterior ramus is an innervation for these muscles. The multifidus then is going to be another major named muscle and really crosses that lumbosacral junction. And so it's not just a lumbar muscle, but more lumbosacral. It's most medially in what we call the spinal gutter. And so it's just lateral to the spinous process and functions in a unilateral way to rotate the vertebral column contralaterally. So if the right multifidus is acting, left rotation results. But when functioning bilaterally, it will actually extend the vertebral column. And again, works as a stabilizer of the lumbar spine. Really, some accounts will project up to 2/3 of the stiffness of the spine is contributed to from the multifidus. And what's interesting is Reiman and colleagues in 2010 looked at the role of the lumbar multifidus in chronic low back pain in the Journal of Physical Medicine and Rehabilitation and found that atrophy is actually present in 80% of those that were presenting with chronic or persistent low back pain. Finally, we get to the abdominal muscles, which again are a group of muscles that are made up by the rectus abdominis, the transverse abdominis, internal and external obliques. Rectus abdominis produces a torque during flexion of the vertebral column and really is a sagittal plane stabilizer, while transverse, internal, and external oblique function in multiplanar motions. The transverse abdominis gets a lot of notation and attention within the lumbar spine as the contraction produces kind of a rigid cylindrical stiffness enhancement to not only the spine but also to the visceral cavity. We'll talk more about whether or not this is something that is as effective as once thought. And then the internal and external obliques, keep in mind a good way to think about these are pockets in, pockets out. There's an inverse relationship there. So internal oblique, it's pockets out. In external oblique, it's pockets in, if you're trying to think of how those fibers are oriented one onto the next. Lumbar fascia has both an anterior, middle, and posterior layers, serves a number of roles, not only in terms of muscle attachment for the transverse abdominis, but also in terms of protecting from shear and other motions that can create more or less challenges to stability of the spine. Segmental flexion is resisted, as well as helping in terms of transmission of extension forces. The movements, again, are primarily flexion and extension throughout the lumbar spine. There is a small amount of lateral flexion and rotation that exists. We saw that on the second or third slide. The capsular pattern is a pattern that's been proposed where lateral flexion and rotation are equally limited, followed then by extension, with flexion often not being limited from a capsular restriction, but more from a disc pathology restriction. As we now move into biomechanics, note that flexion is really the big piece of the lumbar spine. It's well designed for that flexion or even a hinging style motion. Most commonly, we use flexion throughout a variety of ADLs or activities of daily living. There is an unfolding or straightening of lumbar lordosis that occurs with that. And really, we only see minimal movements out of that lordosis with flexion, such that segmental movement in flexion extension is 12 degrees in the upper lumbar spine, but increases to 20 to 25 degrees, really between that transitional period of L5 and S1. When flexion occurs, it produces an anterior roll and anterior glide of the vertebral body, one on top of the next, such that the inferior facet moves upward and backward. L1, 2, 3, and 4 all share a coupling pattern such that side bend and rotation occur in opposite directions. However, as you get into L4, 5, and 5S1, the coupling pattern is side bend and rotation occur in the same direction. So let's look at that a little bit further, specifically with flexion and extension. As you move into flexion, the superior vertebra will anterior tilt and forward glide. That allows that intervertebral foramina to widen by approximately 24%, but it does create an anterior compressive force on the intervertebral disc such that the anterior segment moves the nucleus pulposus posteriorly. This is a proposed mechanism for why someone that has a disc pathology would be flexion intolerant and in turn would prefer extension. Tensile forces then are placed on the posterior annulus, the ligamentum flavum, as well as the capsule and posterior longitudinal ligament. And again, this is a rationale for what are known as Williams flexion exercises, which are geared more towards a stenosis style of patient and not a patient who has discogenic pain. Conversely, with extension, the superior vertebra will tilt and glide posteriorly, and this narrows that intervertebral foramina by up to 20%. Additionally, what's interesting is the central canal is also narrowed, and so if there is an issue of space-occupying lesion, disc prolapse, protrusion, herniation that is impinging upon the central canal and spinal cord, this also will be more narrowed. In this case, the nucleus pulposus moves more anterior due to the compressive force on the posterior aspect of the intervertebral disc, and in this case, the facet joint will begin to close. The major components that resist flexion are the joint capsule as well as the supraspinous and interspinous ligaments, followed by the ligamentum flavum, and finally the intervertebral disc. Structures that are anterior to what is known as the fulcrum will be elongated with extensions, so that would be the anterior longitudinal ligament. The intervertebral disc does resist due to the role of compression as well as the joint capsule being placed on tension. Finally, passive tension of psoas major of the iliopsoas group will also resist end range extension. Moving now to rotation, 65% of the restraint here is seen from tension or impaction of the contralateral facet joint, as well as the supraspinous and interspinous ligaments, while a third is from the intervertebral disc itself. Again, keep in mind the orientation of those annular fibers, one layer onto the next. What's interesting is in a healthy, or what we may say normal individual, the facet joint or the zygapophyseal joint really does serve a large protecting role in terms of providing some form of, for lack of a better term, protection to the intervertebral disc from any type of rotational, torsional, or shear type injuries. Side bending or lateral flexion is a complex movement in the lumbar spine with a coupling again occurring from 1 to 3. Then as you move into 4, 5, 5S1, it's to the same side versus contralateral above. There are a wide range of anomalies within the lumbar spine. We'll talk about this more as we move into differential diagnosis, and we'll revisit again as we move into the pelvis and SIJ. But we can see lumbarization, which is what you see here, where the segment of S1 is actually mobile and acts almost as a sixth lumbar vertebra, meaning it's not fused to the rest of the sacrum. We can also see sacralization, which is where the L5 vertebra actually fuses to the sacrum or ankyloses. And that's actually a common variation that's actually seen with age, more so in men. Very few females actually present with this. Here you can see then the sacralization of L5. That is apparent, as you can very distinctly see and make out the transverse processes as well as the inferior and superior facets. However, it has fused to the sacrum. Finally, let's consider the role of the intervertebral disc in terms of disc pressure. Intrinsic pressure within the disc is about 0.7 kilograms per centimeter squared. As you load or unload the disc, though, there are changes. So by adding weight and lifting, you can increase the load on the disc, as well as by bending, sitting, and lying. Nachemson is the one individual that is most noted for kind of looking at some of the different roles and spinal postures and positions that increase load on the spine. And he showed this in a graph, which is on the next slide, such that lying down is only 25% load, vertically standing is 100% load, or equal to 1, bending forward 150, bending forward with weight 220, and then performing that in a seated position, bending forward, is 275. However, one thing I want you guys to think about, and this is a quote from Peter O'Sullivan, is that load is actually healthy for the spine. And so he argues that it's a flawed argument to link disc pressure to pain. If disc pressure is bad, we should tell people to lie down. We're going to talk more about that as we move into differential diagnosis and as we start to discuss varying spinal pathologies and the role of load, both in terms of its presence as well as when we take load away. So keep that at the forefront of your minds. And that concludes our review of the functional anatomy of the lumbar spine, kinesiology, and biomechanics review. Thank you.